Okay, yeah, sure, that sounds good.
Great. So, alhamdulillah, we're back again with Professor Madbak, the Associate Professor of Surgery, and he's the Director of the Acute Care Surgery at the University of Florida in Jacksonville. And we're on the second part of abdominal trauma. So, take it away, Professor Madbak.
All right, good afternoon, everybody. Thank you all for joining. Thank you for having me again. Just to kind of recap from last time, for those who were here on the 23rd of May, we basically touched on kind of the first part, did a whirlwind tour of the abdomen, discussed the principles of damage control. We're going to touch on that again on this hour. I'll try to flash through the slides really quick and see if there's any questions at the end. So we talked about the management of liver, pancreas, spleen, and then bowel injuries last time. And this hour, I'd like to focus a little bit more on genitourinary injuries, so the urologic trauma that you guys are seeing. So kidney, ureter, bladder, and then if you have time, we'll wrap up. We'll talk about some pelvic fracture management as well. So that'll be kind of the second part here. So, as part of kind of the case-based learning, cases like this are fairly common, unfortunately, with the onslaught that's been going on. 34-year-old male, transpelvic gunshot wound, rise hypertensive to the trauma bay. The pelvis is full of stool, urine, blood, so contamination, hemorrhage, it's packed, sigmoid colon's injured, stapled off. The iliac vessels are intact, but patient's coagulopathic bleeder from the entire bladder mucosal surface. So these are the kind of polytrauma, multiply injured organ systems that, we'll see, and we're gonna kind of work through these. So kind of work through going from the GU system proximal to distal. So talk about kidneys, again, ureters, bladder, and then pelvic fracture management. So we talked about this last time briefly, the damage control goals. Again, just to recap, hemorrhage control, everything, all your energy should be focused on control of the bleeding. And in this case here, we're going to talk about particularly like urinary contamination or soilage. And then again, identify injuries and reconstruct if possible. So the concept of damage control is really applicable across surgical specialties, and urology isn't an exception. And again, your energy should be focused on hemorrhage. The goal is to stop the bleeding, again, not to necessarily raise the blood pressure. And even though urologic guidelines in general tend to focus on organ preservation, traditionally urologists are taught that most or all injuries are definitively managed at the time of initial presentation. So for us simple trauma surgeons, it's a little different kind of paradigm, different mindset. And for them, maybe it's a tough pill to swallow, but in general, we want to consider stabilizing the physiology more importantly than organ preservation. So just like we say life over limb, it's life over kidney in this case. And a lot of times, a collaborative approach is crucial if you have access to a urologist. But in general, patients die from bad physiology. They don't die from anatomic injury. So you want to focus on control of the hemorrhage and not necessarily preserving the organ if the patient's in dire straits and extremis. So that's kind of the approach we want to use. But an integrated approach, if possible, if multiple specialties are available. I understand sometimes that's not an option. But in general, again, live to fight another day, go back in 48 to 72 hours. So as far as urinary extract, it's less of a priority actually than fecal contamination control. So, and certainly both are less of a priority than hemorrhage control, as we said. But in general, allowing urinary tract injury to drain into the abdominal cavity for a limited time shouldn't typically result in general in any major adverse sequelae. So temporary diversion options exist and are more desirable, but urine in general is less of a caustic, reaction to the viscera than GI contents. So it does create a significant inflammatory reaction with time, but an early control is desirable. But if it's not possible and it's delayed because you're addressing other injuries, then the inflammatory response isn't as profound, isn't as severe. How about preoperative imaging? You can correct me if I'm wrong, but my understanding from talking to colleagues is that a CAT scan of an abdomen, pelvis, and Gaza is really not as widely available, not as feasible in certain hours, but CTs of the head are a little bit easier to get. In general, it sometimes will waste your time. And most urologic injuries, if you're exploring the abdomen, like the case we discussed for other injuries, you can make a diagnosis intraoperatively upon exploration. So it may not be available in your case, and it may not be, honestly, it may not be necessary. Again, in general, urologists are trained to, not to pick on them too much, but they're trained to operate on the injured kidney where, with preoperative imaging to confirm the presence of two functioning kidneys, because they don't want to do a nephrectomy and then have a dysfunctional contralateral kidney and end up making a patient, dialysis dependent with no renal, normal renal function. In general, you can actually make that assessment again intraop about the other kidney. We'll talk about that in a second too. And then lower tract injuries, so critical information about the bladder and the and even the urethra, which we won't really touch on too much today, can be obtained in the OR. So talk about kidney injuries, just kind of an overview in civilian neurologic injuries, not in combat setting or during a conflict where you have a lot of penetrating trauma, a lot of blast injuries. But in civilian trauma, a lot of it is blunt, due to blunt mechanisms, 80 to 90% of those, and the vast majority can be managed non-operatively. So oftentimes they're low-grade injuries that you can watch. In terms of the case that we talked about, this is a different case. We'll come back to the one we mentioned, but this is a 27-year-old male, real case again, multiple fragments of the flank after a massive explosion, hypotensive, positive ultrasound, so positive fast exam, free fluid in the abdomen. Went to exploration, and there's a large right retroperitoneal hematoma. Remember, we talked about the zones of the retroperitoneum last time. So zone 2 would be the perinephric or flank hematoma. Gerardus fascia, the fascial envelope around the kidney is open, the right kidney is delivered, and there's multiple fragmentation wounds all over the kidney. So kind of talk about, should you take out the kidney, should you try to salvage it? And these are the things we're going to talk about today. As far as diagnosis, if you have any hematuria, if you put a Foley catheter in, and there's any hematuria, assuming that it goes in without resistance, then you have to think about a renal injury. Gross hematuria is common even with minor trauma, and the amount actually is incongruous with the degree of injury. So the severity of injury or the grade doesn't correlate with the amount of hematuria. You might see a lot of blood in the urine with a minor injury that you'll manage not operating in a stable patient. And the abscess of hematuria can be seen. It's not that high of a rate, but in pedicle injuries, you may not actually see enough to be seen, with the naked eye, gross hematuria. We used to get excited about microscopic hematuria, not so much anymore, unless it's a pediatric patient. Sometimes if you have a blunt mechanism in microscopic hematuria, you may be tempted to get an image, a scan if it's available to you, to delineate further. But in general, it's gross hematuria that you wanna focus on. As far as indications for exploration, again, it's guided by hemodynamics, guided by stability. So if you're in the OR and there's expanding zone 2 hematoma, expanding perirenal hematoma, then in general, you want to explore it, especially in a penetrating mechanism. Relative indications, less of an urgency, but again, relative indications are urinary extrav, any non-viable tissue, any hilar injury, segmental arterial injury. So these are the things that you'll find in the operating room, but can be elucidated as well in the on a scan if it's available. So evaluation, the mainstay again is a CT scan, and then somebody mentioned this last time about fast or diagnostic peritoneal aspirate. We don't really do diagnostic peritoneal lavage much anymore, but remember, fast is specific, not sensitive. So a negative fast is not very helpful. A positive fast will, be indicative of intra-abdominal trauma that in an unstable patient would be an indication to explore. But it's unreliable here for renal trauma because, again, it's in a retroperitoneal location. So you might miss those just if you rely on it fast. So that's why scanning, if they're stable, is a better imaging modality. So again, if it's available, you're looking for extravasation, any perfusion. You might see a sort of a stretch injury of the renal hilum that causes hyperperfusion or ischemia to the kidney. And then look at the contralateral kidney. So it's 98% sensitive, and that's why it's the better test. If you can, usually you would do it 5 to 10 minutes, depending on your institutional guideline or protocol. A delayed phase CT scan, which represents a pretty valid tool in diagnosing ureteral and ureteropelvic injuries. It's a CT urogram, if you will, urographic phase, and it can validate the entire GU system. So they would scan with IV contrast, ideally, and then wait for, depending on where you are, 5 to 10 minutes at least, and then rescan. And by that time, the contrast would have lighted up in the GU system, the renal pelvis, and all the way down into the ureter and the bladder. So you can see if there's any urinary extrav or ureteral injuries. Grading system, you don't have to know these, but it's every organ system has an organ injury scale by the American Association for the Surgery of Trauma, or the AASD. Basically, solid organ injuries go through 1 through 5. So liver, spleen, kidney are the ones that we talk about the most, but even the ureter has one, but it's not really of any clinical importance. But usually based on contusion or hematoma and laceration, so based on size and extent. So grade 1 is a contusion, no imaging abnormalities or subcapsular hematoma. Grade 2 will be a perinephric hematoma confined to the peritoneum. So there's no free massive, hemiperitoneum into the peritoneal cavity, and then a small laceration, so up to 1 centimeter. Grade 3 is greater than 1 centimeter in the parenchyma. 4 is a laceration through the collecting system. And then 5 is a shattered kidney or vascular avulsion, so a hilar injury. And here again is when we say, life of a kidney, this is a kidney that probably should just come out. If there's only isolated urinary extrav, which is rare, but that in itself, again, is not a reason to do an nephrectomy. So it's not a contraindication to even operate on the kidney, because that can be drained if possible. If there's other indications for laparotomy, as in the patient we discussed, typically there's other injuries. The priority would be to address the other injuries first, and we'll talk about that a little bit more in more detail. But in generally, if a patient's stable and has a renal pelvis injury, there's urinary extrav, that can be considered for delayed management. Doesn't have to be addressed right away. And of course, the patient may have other injuries that require stabilization, like a traumatic brain injury or a pelvic fracture or what have you. But in low resource settings where there's austere circumstances and not a lot of resources in a stable patient, non-orphan management could be considered if there's no other injuries that need to be addressed. And then once the patient is has other injuries addressed, that can be addressed with drainage or some other modality just to control the urinary leak. So the operative scenarios now for renal trauma or penetrating trauma, again, to have an isolated renal injury will be quite rare. Blunt trauma, say with a blast injury from explosive devices, and then blunt trauma like falls or other blunt trauma, high speed trauma that would require exploration for other indications, and you would have to explore the kidney, doing your systematic exploration at the same time. As far as treatments with respect to grading now, 1 through 3 really can be observed and do not require any intervention. This is incidentally found in a patient with other injuries that can be left alone. Again, stable, not expanding. If they are and the kidney is explored, then you can do a kind of a organ preserving renal salvage, and then do a kind of like we talked about splenography last time. If the patient is stable, but there's a extensive, grade 3 laceration that can be repaired if you deliver the kidney. It used to be said, if you deliver the kidney or you're committed to doing a nephrectomy, not necessarily. If you can fix the kidney, you can fix it. But again, you have to consider the physiologic derangement of the patient. So it's all about, hemodynamic stability. Grades 4 to 5 typically repair, again, in a stable patient, but a patient who has a shattered kidney and they're unstable, then certainly here, life of the kidney again, you would just do a nephrectomy and kind of move on to other priorities. As far as the operative technique now, we talked about the spleen. The good news is the spleen and the kidney are actually very similar with respect to again, it's a simple trauma surgeon mind. It's a single vascular pedicle, and it's a kind of a lateral organ that you can medialize. So in general, remember we talked about the Maddox maneuver, or the left medial vessel rotation. Basically, you don't need to actually do that exposed retroperitoneum, but again, the small bowel goes up to the right, and the transverse colon goes up first, and then small bowel gets eviscerated to the right. And then, let's say we're trying to tackle the right or left kidney here. A lot of times, if you look at textbooks or talk to urologists, when they do nephrectomies for elective surgery, like for cancer, they oftentimes are trained to manage, approach a nephrectomy by high level control, so at the origin. So basically, they would isolate the renal artery and vein at its origin centrally, like in zone 1 of the retroperitoneum, basically, and try to loop the vessels there. That tends to take time, and it's a little treacherous area. And if you're in a rush, honestly, one way to do it is just to medialize it like you do a splenectomy, because you don't want to be dissecting, around the cava if you're in a pinch. So once you're in the abdomen, however, you should address any intraperitoneal hemorrhage before attacking a renal injury. And the reason is because of that Gerota's fascia, the retroperitoneum provides some containment, some tamponade for most renal hemorrhage. So typically you would, pack the injury, even if it's ruptured through a hole. Typically in penetrating trauma, you might see a hole through it. And with direct pressure, either with a sponge or some hemostatic agent, if it's available to, just pack it, and then, address other injuries and come back. Because there's not going to be free hemorrhage into the peritoneal cavity. So if the perirenal fascia is violated, and there's some renal cortical bleeding, packing it tightly will salvage it in an unstable patient. And then oftentimes actually would again lend itself to damage control. And if the patient's unstable, you want to get them off the table. At a future operation, the packs can be removed, the wound area, then you can reassess. Are you going to repair it? Are you going to take it out, or what have you? You can inspect it. But so if you decide either at the second look operation or at the time where the kidney is just not salvageable, that you are actually committed to doing a nephrectomy, then here's how we would do it. Instead of going centrally, again, lateral mobilization. So open Gerotas. There's nothing there you can hurt laterally, and just take your hand behind the kidney and lift it up, make it a medial organ, like you do with the spleen, and then clamp the hilum, clamp the ureter, and then you're done. Essentially, tie it off. So it shouldn't take more than a few minutes, and it's quicker, frankly, than going centrally and looping all these vessels, off the aorta or draining into the IVC. Now, if you do that, we discussed, was the contralateral kidney normal? Are we going to take a kidney out and then render a patient without a renal function? And generally, if you feel a normal kidney on the unaffected side, then you should be comfortable in performing nephrectomy on the injured side if needed, without the fear of making them dialysis dependent. In the unusual case that, let's say it's an elderly patient and you palpate an abnormal kidney, either it's atrophic or polycystic or has some pathology on the unaffected side, then you can consider doing one of those IVPs. I can't say that I've ever done one in my life, not to show my age, but in general, I'm told it's very, it's technically difficult, and it's often inadequate, and most importantly, it's very time consuming. And the most important key point here is that this patient might be hypotensive and you're doing a rapid nephrectomy. If they're hypotensive, then injecting contrast, it may not actually light up because they don't have enough flow to light up the renal pelvis on the other side. So idea here is to see if there's any filling, and oftentimes you get this fuzzogram that you can't even interpret. So another kind of useful technique to assess the renal function on the other side is to, if you have a dye of some sort, methylene blue or indigo carmine, some sort of dye that anesthesia has access to, you can clamp the ureter of the injured kidney So the one that you're taking out, and then give the dye IV, and then wait, 5 to 10 minutes. And generally, if you see the urine turn colors through the catheter, then you can rest assured then the other kidney is working, and then you can go ahead and just do an nephrectomy. So it's a less conventional option, but it's more expeditious, and it's pretty atraumatic to just occlude the ureter of the injured kidney. It's coming out anyway, and then just give the dye and see if there's urine, if the urine changes colors. So this is, again, I understand the CAT scan isn't always available, but if this is the algorithm, if you have a renal injury on CAT scan, again, stable patient, low grade 1 through 3, usually you observe if there's extravasation of contrast, IV contrast now, not urinary, then you can consider angiography if it's available. And again, unstable patients or devascularized kidney, typically you can do things like 8 grams and stents. But in general, if they're unstable, most of the time they're gonna end up, on our hands with a nephrectomy for the injuries that we're discussing. If there's a urinoma, and again the kidney is intact, so it's a renal pelvis injury, then you can consider percutaneous drainage and just to control the urinary leak, so you can salvage the kidney that way. As far as damage control for renal injuries, again, packing typically works. It used to be said that if there's any penetrating mechanism and if there's any zone 2 hematoma to a penetrating mechanism, that it should be explored. If it's not expanding, just leave it alone, and it's unlikely to be involving the renal hilum, the renal pedicle. And choosing what to pack with, if you have kind of hemostatic agents, now everybody on their mother, wants to make a hemostatic agent and sell it to either the military or sell it to I mean, all these companies are on the horizon now, but if it's anything that can sort of cause an activation of either thrombin, fibrinogen, these are sometimes can get expensive, but sometimes blood products aren't available to start a resuscitation, so they can generally maybe control the hemorrhage a little bit better than just run-of-the-mill standard lap pads. So that's an option as well. If you were going to do any renal salvage procedure, kind of like in the spleen or the liver even, if you have gel foam or some sort of Surgicel kind of hemostatic dressing, you can use it kind of as a packing and then suture over it. So you use some absorbable, sometimes chromic or Vicryl, and just sew through the kidney. It's a little bit easier to sew through than liver. Sewing through the liver sometimes it's like sewing through butter, and the suture will rip through. But in general, here it has a little more integrity. Or you can use an mental flap like we did in the liver last time. So that's another option as well. If it's isolated, this is not very common. If it's isolated to the one side of the kidney, inferior or superior pole, then conceivably you can do a partial nephrectomy. And that's an option as well with either platelet repair, just take off all the devitalized tissue and then try to control the kidney. But again, stay away from the fancy stuff, especially in an unstable patient. You don't want to be wasting time doing all these maneuvers. So in general, that can come back for kidneys, and unstable patient, just take the kidney out, and most of the time in a young patient, the other kidney should be just fine. Okay, what about the ureter? So basically, this is another patient here. It's really pretty straightforward here because usually it's a penetrating mechanism again. So he's another patient. Gunshot to the flank, hypertensive, large cecal perf, psoas muscle bleeding, it's packed, and then the right ureter short-circuit. So usually associated with associated injuries that are kind of to adjacent organs. Extremely uncommon in blunt trauma. So you'll see it with a gunshot more commonly. And in a combat zone that we're discussing. Any injury to blood vessels in the area, so iliac vessels, any bladder or right or left colon injury should really kind of prompt you to take a look at the ureter. Not necessarily at that time, but it's something you should be thinking about because again, it's in the neighborhood and it's retroperitoneal, so it's something we should explore or look at some point. Now, as far as the methylene blue that we talked about for evaluating the contralateral kidney. You can do that to look for an occult, a hidden like ureter injury. It doesn't always work. So we've done it, and then we've had the luxury, obviously, to scan post-operatively to look for other injuries that we won't find, like thoracolumbar spine injuries and pelvic fractures and rib fractures or what have you. But and we've seen ureter injuries on the scan that in the OR when we give the methylene blue. So basically here you give the methylene blue, throw some packs in the pelvis, and then look at them, kind of read them like tea leaves, open them up. If they turn colors, then you have a leak somewhere, and you have to think about a ureter injury. But it's not foolproof. It's not 100%. So now, as far as how you treat these, you want to base your management on the portion of the ureter that's involved. So it depends on if it's proximal, mid, or distal ureter, and again, of course, patient stability. So here, damage control is the norm. So the risk of bleeding here is obviously, essentially non-existent. So again, the priorities are hemorrhage control. So you don't have to worry about repairing it at the time of injury. If the patient's stable and you have the time, there's no more casualties coming in, and you have that luxury, sure, but it takes time, and it's not really, there's no urgency. How do you do damage control for the ureter? Temporally intubate it with an externalizable stent of some sort. If you have a single J, ureteral stent, great. If not, just use whatever you can get your hands on. So a pediatric feeding tube or a small NG tube, something that you can use as a tube, small chest tube. The stent is placed through the transected or lacerated ureter, passed proximally toward the kidney, so it lands in the renal pelvis. And then when it's positioned properly, the J stents have a guide wire, and they can be then removed once you're secured in position. And then you tie the stent in place around the ureter with like a 3/0 silk suture or whatever suture you can find, really. And you compress it a minimum amount. So as it kind of enters the ureter, about 1 to 2 millimeters of ureteral tissue within the tie is kind of cinched around. And then the distal stump of the ureter will drain through the drain, and then you can actually bring it out through the skin. So this is the ureter here, and that's the stent, and you can bring it out through the skin, almost like an ostomy of some sort. They can drain, you connect it to a bag or just drain urine. So that's one option. So you drain and kind of get out of dodge. The other option is to just ligate the proximal ureter. And again, here you need like a multidisciplinary team. And if you have interventional radiology capabilities, because you have to do this with fluoroscopy, is to place a nephrostomy tube. Now you can do these open, but in general, I know radiology and fluoroscopy is limited. But it is more cumbersome. But if you have the capability to do interventional radiology, technique, then that's an option. But generally, just intubate it, bring it out, and then come back and fix it later if you need to get out. As far as definitive management, a ureterostomy basically means just putting it back together end to end. A ureteroneocystostomy is reimplanting the ureter into the bladder. A ureteroneocystostomy, so ureter new and then into the bladder. This is what you do like in a renal, a kidney transplant, same technique. This for distal injuries. And then you want to separate your repairs. So if you have a pancreatic injury that we drained, like we did last time, then you don't want that pancreatic juice or, an anastomosis from a colonic injury to be, contaminate your repair should you have a leak. So if you have tissue flaps that you can create, or psoas or Amentum, or just something just to kind of isolate your repairs and protect your repairs. So you want to separate it from any adjacent anterior converse, some sort of interposition viable tissue. So how do you find the ureter? We discussed, this patient had a cecal perforation located generally at the level of the iliac bifurcation. So we say water under the bridge. Water under the bridge meaning the gonadal, not the iliac. So it goes over the iliacs, but under the gonadal. So the ureter kind of goes under the gonadal vein and artery, and then over the iliacs. So if you find the bifurcation of the iliacs, where the common bifurcation of the internal iliac, and usually ureter is kind of going over. You want to mobilize the right or left colon. along the lateral perineal flexion, lift it out of its bed, and then look for the iliacs and find it there. You don't want to mobilize and dissect out the whole ureter, like skeletonize the whole ureter, because if you remember, the blood supply is segmental. So if you do that, you've created an ischemic ureter and you jeopardize the blood supply of the injured ureter. So you only want to isolate the portion of the ureter you want to look at. Don't like strip it all the way up and down. If you're going to put it together, then again, over a stent to avoid stenosis, and just use whatever absorbable suture you can find, usually absorbable monofilament. And the usual teaching use absorbable because it's an item for like stone formation. So something like, these are all brand names, but monocryl or PDS or something absorbable in general should work fine. And then, debride the tissue, spatulate, and just put it together end to end over the stent. You can do this usually interrupted. You could run it, but just so you don't narrow it down. In terms of the proximal ureter, I've never done this or seen it done in my life. Again, it's almost like making a hole in the duodenum to study the pancreatic duct, or making a hole in the gallbladder. You're creating a problem that you didn't have before, but this is basically a crossover transureterostomy. So basically taking the contralateral uninjured ureter and making a hole in it, plugging the injured ureter into it. It seems to make sense intuitively, but it's really not recommended because, again, it puts the uninjured kidney at risk. So you're creating a problem that you didn't have before, and that's not a good idea. If it's a mid-ureter, there's a lot of tissue loss. If you have a urologist, that might be helpful because it's not something that we do often. But you can tubulize a flap of bladder and create what we call a Bowari bladder flap, and that's the most of the ureter to the kind of tubulized bladder. And then another option is a psoas hitch. So you tack the bladder wall to the psoas muscle, and it creates a little bit more length if you have tissue loss to create a tension-free ureter neocystostomy here. So that's called a psoas hitch. Okay, doing okay on time. So moving on to the bladder now. This is the case we discussed at the very beginning that we mentioned. So the transpelvic gunshot wound, and the bladder mucosa, just like the gastric mucosa, bleeds a lot. And if you have a ruptured bladder, that usually can be a source of a lot of hemorrhage. So oftentimes the mechanism here can be blunt or penetrating, unlike the ureter. In general, if you have a patient with a full bladder and there's a blunt mechanism that impacts the anterior, the pelvic girdle, pelvic symphysis, you can have a dome rupture, especially in a full bladder, kind of a blowout of the dome of the bladder. If you have a pelvic fracture and gross immaturity, you have to assume that there's a GU injury of some sort, typically in the lower GU tract. So you have to assess the bladder and the urethra. And the way to do it typically is with a retrograde urethrogram. You can do this in the trauma room in the emergency department. And then, of course, as in this patient, penetrating mechanism usually due to a gunshot. The high energy necessary to damage the bladder, due to that, really, a lot of patients will have a concomitant pelvic fracture. So you have to think about both. And then bladder injuries in general come in two flavors, and we're gonna talk about that. But if you do, if you come upon a bladder injury in the operating room, then you want to look at everything. So you want to look at the dome. Sometimes you have to actually make the hole bigger if there's a hole in the dome, to look at the bladder from the inside, because you want to inspect the ureteral orifices and make sure there's no renal, a bladder neck injury. So typically, just like the stomach, because of the blood supply, they lend themselves to definitive repair. You don't have to do a suprapubic catheter for most bladder injuries, and a lot of them can be repaired. You're not going to narrow this, obviously. So they can be repaired and then drained from the inside universally, but external drains, unless you have other injuries, not typically required. But if you're concerned that it's a kind of a tenuous repair, it might be a good idea, but it's not the rule. As far as damage control, again, this could be exteriorized. So here, you can either do a transurethral, so a typical, your normal run-of-the-mill Foley catheter, or a suprapubic cystostomy catheter. If the patient needs to be resuscitated before they come back. Extensive bladder injuries, you can actually stent up the ureter orifices and exteriorize, kind of divert the urinary stream until you can definitively repair. But if it's smaller hole, you can just go after it. And so again, absorbable suture running or interrupted, typically in 2 layers, but 1 layer should be sufficient as well in a pinch. And then, you know, pack the bleeding and externally drain if you're gonna do damage control. As far as diagnosis though, if you're not in the operating room and you want to diagnose because there's hematuria, there's a pelvic fracture concern, again, the patient's stable, you're not operating on them for another reason. This is an option if it's available to you, is do a CT cystogram, but you can do a cystogram with X-ray, just backfill the bladder with 400 cc's here of contrast, not 50, and then shoot an X-ray and make sure. It can miss some because you need a post void and a lateral. That's why if it's available, CT usually kind of streamlines that process. But and if you diagnose an injury, again, they come in 2 flavors. So there's extraperitoneal and intraperitoneal. Extraperitoneal bladder injury is usually secondary to any bony fragments from the concomitant pelvic fractures. And the treatment here is just drainage, just a Foley catheter. The only exception to this rule of the 7 to 10 days drainage of extraperitoneal bladder injuries is if you are having your orthopedic colleagues do pelvic fixation with hardware, then these need to be repaired. Extraperitoneal bladder injuries need to be repaired because you don't want the orthopedic hardware to be bathed in urine. So in general, if you have a pelvic fracture that requires fixation, not an iliac wing or a pubic ramus that's going to be managed non-operatively, but if it's an unstable pelvis, you're going to do some internal fixation with hardware. Even in the face of extraperitoneal bladder injuries, those should be repaired. But the vast majority, in the absence of that, you can just drain with a Foley and they should heal. So this is how kind of a lateral kind of schematic of the extraperitoneal rupture, and then on an X-ray it'll look like sort of this contrast line of the bladder around the bladder base on the cysto. If you have intraperitoneal bladder or a dome rupture like this, you have free intraperitoneal urinary contamination. It'll kind of look like a sunburst over the dome. So if the contrast is pulling kind of around the base, then usually that's extra. If it's all over the abdomen superiorly, then it's intra, and those need surgical repair. So again, CT cystography, again, if it's available, was compared, and it seems to be pretty reliable whenever possible. So repairing the bladder, again, 2-layer absorbable closure, identify the ureter orifices. If it's a dome, you can just, again, you're not going to narrow it. And then a Foley, and again, optionally a perivesicular or external drain. So after the repair, usually you leave the Foley for 7 to 10 days, depending on who you read. And then the cystogram, some authors looked at this. It's not mandatory. That's typically most people's practice to do a cystogram if you can before you take out the Foley, just to document repair and there's no other leak. But that's, again, generally in a lot of civilian trauma, that's, and it's kind of not multifocal injury, you can skip that. Okay, complications of urologic injuries. Again, urinary leak that you drain, long-term risk of hypertension in case of renovascular trauma. And then, again, if you're bailing out, a brief period of urinary leak is okay in general. Of course, abscess infections, and then ureteral strictures in the case of ureteral trauma. And again, stay away from the fancy stuff, kind of keep it simple when you can. Drain, kind of liberally, and then come back if you need to. Okay, so switching gears, kind of related topic, because these often occur simultaneously. But in general, pelvic fractures kind of lend itself to a lot of multidisciplinary approach. These are usually, again, different flavors, kind of subclassified as lateral compression, vertical shear. These are the unstable. The unstable fractures are the ones really on the bottom, and then this one here, the windswept pelvis. So lateral compression typically considered a stable fracture, meaning it won't present with hemorrhagic shock and you know, a hypotensive patient. But vertical shear and AP compression, or what we call the open book, kind of like the X-ray here, a widened symphysis or an open book fracture, that's due to an anterior posterior or AP compression. And those are unstable and need to be addressed usually immediately. So what's the problem with operative hemostasis in the abdomen if you suspect there's pelvic trauma? It really releases containment and releases the tamponade. I've never had a patient survive where you open the abdomen and actually release, you know, all this venous torrential hemorrhage in the pelvis and try to control from the abdomen. It's usually disastrous. So it restarts venous bleeding, and it's really hard to find what's bleeding in a shattered pelvis. The one salvage kind of last ditch effort is to just ligate both internal iliac arteries or hypogastrics, or embolize them if you have the option. But in general, the optimal care, and we'll talk about these, but just to summarize, is to use a pelvic binder, and then smaller arterial bleeding if you have radiologists around. And again, I understand that's not really a widely available resource. You can use embolization, and then any major arterial bleeding you may have to explore if you can localize, but typically it's not something that you would do through the abdomen. So external compression works because it reduces pelvic volume, reduces fracture fragments, it stops venous bleeding, and it kind of stabilizes the clot, so to speak. And again, it helps you with transport. So it limits the fracture motion, it limits pain during the transport if you're moving the patient from one phase to another. And there's all sorts of commercially available devices that if you go to different emergency departments, they might have these that different companies come up with. But in general, honestly, like in a pinch, and I've worked in a place where, you know, resources weren't abundant, and you could just use a sheet. So the key here is that it has to be centered over the greater trochanter of the femurs. So oftentimes you see it kind of riding pretty high. So this is good placement here. You want it to, you don't want it up, you know, around the abdomen. So you want the center to be around the greater trochanter. And you can do that with a sheet again. You don't want to, you know, log roll the patient with an unstable pelvis. So one way to do it is to slip it under the legs distally, and then kind of shimmy it up back and forth until you get up to where you want it superiorly, and then wrap, tie, you know, you can't see it here, but tie a knot. Some people wet it just to kind of secure the knot, and then, or use clamps, hemostats, Kelly clamps, whatever you can get your hands on, just to kind of swaddle and close down the pelvis. In terms of fixation, if it's available to you, and it's something that you have a frame, it's the most rigid fixation they can get done. Again, the same principle, closes down the pelvis and treats venous injuries. It's applied pretty quickly, but the problem is you need a fluoroscopy to identify all the anatomic landmarks. And it may be the definitive fixation, but it temporizes fixation externally. It may actually displace posterior elements. This is one of the commercially available, it's called a C-clamp that you can do. So in general, that's another option if, you know, if it can be rapidly deployed. And this is beyond the scope of this talk, and we won't really talk about it, but endovascular techniques like the Ribot balloon. Ribot just stands for resuscitative endovascular balloon occlusion of the aorta. The data is all over the place with this, and honestly, I'm not sure it's going to survive. It probably will survive because there's a lot of money behind it, but because the company keeps pushing it. But it's something that you'll read about, zone 3 deployment to kind of as a bridge to fixation, is to deploy the balloon just above the bifurcation of the iliacs and get proximal control that way. But again, a lot of time, a lot of equipment, a lot of complications, and jury's still out whether it's something that, but you know, some centers are using it, but just to kind of, just for completion, just to mention it. Now, again, just like we talked about in GU injuries and really everything else, stability will, especially here, will guide your management. So hemodynamics will, you know, dictate your intervention. If the patient's unstable, then you start blood product resuscitation if it's available, and then if they respond, then you can scan them again if it's available. If they don't, then generally you would try to do preperitoneal packing. So what is that? Basically, either through a fan and steel, a transverse suprapubic incision, or usually we do a vertical midline laparotomy. If you're concerned about abdominal injuries, you can actually do an upper midline and limit it to not actually open the peritoneum inferiorly. And generally open the posterior sheath of the rectus, but leave the peritoneum unviolated. If you do it through a fan and steel, usually the orthopedic folks will prefer that. So if you're thinking ahead and you're thinking about them and whoever putting the frame on or the hardware, you can do it that way. You can do an up and down vertical midline laparotomy as you would explore the abdomen and leave the inferior aspect undisturbed and do a fan and steel instead of doing like one hole incision. But in general, the principles are the same. You want to open the anterior fascia, posterior fascia, leave the peritoneum intact. And here you would pack, usually you can get 3 packs in on either side. So you want to go all the way down laterally posterior. You can actually get to the sacrum that way and pack tightly, and it's very, very effective. These are iliacs here. And again, the intervention is based on the hemodynamics of the people who don't respond, the patients who get the blood and don't respond. That would be the next step. After you place the binder that hasn't worked, you need more control. That would be the next step. The pelvic fracture, I know we talked about them. It doesn't predict much, but it just predicts the stability of the fracture, whether we need compression or with a binder or fixation with a frame. If you had managed to scan these patients, the responders now, so you didn't go to pre-peritoneally pack them, they responded, you scanned them. If you have that, you would look for a blush. The blush, the absence of it doesn't really rule out an injury. We've had patients that had, a clean scan and ended up continuing to bleed. And when they did an angiogram, they actually saw some, it was positive and saw some extravasation. But that's something to kind of keep in mind. So it's not 100% reliable. This is the EAST, or the Eastern Association for the Surgery of Trauma, pelvic fracture guideline. Just to summarize, pelvic binders really don't limit the bleeding, but they reduce the fracture in the pelvic volume, so they buy you some time until you get definitive control. Fast, again, it's sensitive. It's specific, not sensitive. So you can use it to rule out intra-abdominal injury. So if you're not sure, a patient comes in hypotensive after multiple gunshots, they're negative X-ray, you're thinking that the money is in the pelvis. You can rule out the abdominal trauma with fast or diagnostic peritoneal aspirate. So here, remember, in a pregnant patient or this patient, pelvic fractures, suspected pelvic fractures, the catheter would go up in the supraumbilical location, not infraumbilical. So you go above the belly button to do the DPA. And if you get positive stool or bile or blood or corn or whatever, then that's a positive tap, a positive aspirate. Then you need to explore both cavities. You pack, a preperitoneal pack, and then again, assuming this patient is unstable, and you have to go into the belly too to explore for any abdominal trauma. In stable patients, again, because of it's retroperitoneal hemorrhage or retroperitoneal bleeding, CT is more reliable. So to summarize, any instability, wrap the pelvis, blood products, responders go to scan, non-responders get packed. Ideally, the frame gets placed right before you pack, but coordinating all that sometimes can be difficult. So it may not happen at the same setting. Just to kind of summarize, kidney injuries, delayed expiration is kind of the rule. Pack and come back. For the ureter, you can divert with external drain, open internal drainage, ligate, and nephrostomy, or repair it over a stent when you're able. Bladder, you can again pack and drain and come back, repair primarily. For the pelvis, really, if you have orthopedic interventional radiology capabilities in an ideal world, not an austere circumstances that we're describing here, but in general, compression and fixation. The balloon maybe has some promise, but it's not something that's really definitive. I think that's all I had. These are the references. I wanted to put this up for you guys to join the mailing list for OxPal is a QR code that you can scan. This is my contact information, and feel free to reach out if you have any questions, if you need anything that, you know, as small or big that I can do. And our hearts go out to you, and we're thinking about you, and stay strong. And Allah يفرجها وينصركم جميعا.
So,
Thank you.
thank you very much, Professor Madbak. Sorry, there's a bunch of people going past, but and I have quite bad service. But thank you very much for your time and for everything you've spoken about abdominal trauma. I think there's so many different types of surgeries that are needed, and there's so many different ways to treat them. And so, if you wouldn't mind, just also for everyone here, please scan the QR code to join our mailing list so that we can be in constant update regarding new things that are happening and new teaching that's going on. But thank you so much, and inshallah, I'll record this soon and send it to everyone. And thank you so much, Professor Madbak, for your time. See you very soon.